Bismillahirrahmanirrahim. Today we are going to discuss a very important and common disease of the children which may also occur in adults, and that is the Nephrotic Syndrome. Nephrotic Syndrome actually itself it is not a diagnosis, but it is an indication that there is some underlying glomerular disease. Normally, the glomerular basement membrane and filtration barrier does not allow proteins to be filtered into the filtrate. But if there is some damage to this filtration barrier, what happens that proteins, particularly the albumin, it starts leaking into the filtrate, and this situation, which is caused by the increased permeability of the basement membrane, glomerular basement membrane, which is caused by some sort of damage, will lead to the clinical complex of the nephrotic syndrome. So, nephrotic syndrome itself is not a diagnosis. We may have 10 patients of nephrotic syndrome, but each patient may have a different underlying abnormality and a different underlying cause. Whatsoever this clinico-pathological syndrome consists of massive proteinuria. By that we mean loss of excess protein in the urine, usually equal to or more than 355 grams per day. So what happens that when the proteins, particularly the albumin, when they are lost in the urine due to increased permeability which is caused by some damage to the glomerular basement membrane, it will lead to hypoalbuminemia, low level of the albumin in the blood, usually less than 3 grams per deciliter. And we know that the albumin is the major protein in the blood which is responsible for maintaining the colloidal osmotic pressure or oncotic pressure. At the capillary circulation, at the arteriolar end of the capillary, the hydrostatic pressure pushes fluid out of the blood into the extravascular space. But at the venular end of the capillary, the colloidal osmotic pressure, which is mainly due to the presence of albumin, it pulls back that fluid. And normally a small amount of fluid may be retained in the extravascular tissue, which is normally drained by the lymphatics. And as a result, we do not get edema. But in nephrotic syndrome, the loss of albumin in the urine, which leads to hypoalbuminemia and decreased colloidal osmotic pressure, results in the failure of the blood to pull back the fluid that is pushed out by the hydrostatic pressure at the arteriolar end of the capillary. And this inability to pull back the fluid into the blood by the colloidal osmotic pressure, which is mainly maintained by the albumin, will lead to the stay of fluid in the extravascular space, and this will lead to edema. Initially, this edema appears in the periorbital region near the eyes, and this is because of the presence of loose connective tissue in that region. However, if the proteinuria persists, the edema may become systemic and generalized, and in severe cases, then it may lead to the severe form of edema known as the anasarca. As a compensatory response, due to low level of the albumin in the blood, the liver starts to synthesize more and more proteins. And along with the albumin, unfortunately, the liver also cause excess synthesis of the lipoproteins, which are lipid carriers. Very low density lipoproteins, VLDL, intermediate density lipoproteins, and low density lipoproteins. So, this increased synthesis of the lipoproteins will increase the blood level of the lipids known as the hyperlipidemia, with its associated complications and consequences. Excess presence of excess lipids in the blood may cause lipids to leak out in the filtrate, and this condition is known as the lipiduria. Most of these lipids are reabsorbed by the cells of the proximal convoluted tubules, the epithelial cells, and accumulation of these lipids in the epithelial cells of the proximal convoluted tubules may lead to the oval bodies, lipids in these cells. So, when we say nephrotic syndrome, we mean a patient with massive proteinuria, hypoalbuminemia, generalized edema, hyperlipidemia, lipiduria, with all associated complications of these conditions. Normally, we know that the afferent arteriole on its entry into the Bowman capsule divides into network of capillaries known as the glomerular capillaries, and these are high pressure anastomosing capillary tufts, and instead of going into the venule, these capillaries will go into the efferent arterioles, which will again divide into the peritubular capillary network around the kidney tubules. But in normal conditions, the glomerular capillary is having an inner glycocalyx, which is strongly negatively charged and will repel the negatively charged proteins and will not allow these proteins to filter into the glomerular filtrate. The glomerular capillary endothelial cells are specialized cells having fenestrations, and they are particular for the process of filtration that occurs in the Bowman capsule, and on the outside they lie on the basement membrane, which is a specialized glomerular basement membrane made up of type 4 collagen and other proteins. Outside the basement membrane there is the visceral epithelial layer are podocytes with their food processes, and the food processes of the podocytes, which are visceral epithelial cells, they interdigitate, and in between the interdigitations there are the filtration slits and lined by the slit diaphragm composed of the nephrin molecules. So, in normal conditions, proteins are not allowed to filter into the glomerular filtrate. The two opposing forces are the size barrier, and the other force is the charge barrier, because the basement membrane, this filtration barrier is negatively charged, and it will repel the negatively charged proteins and will not allow those to be filtered into the glomerular filtrate or to enter into the tubular system. Now, what happens when this filtration barrier is damaged by any reason? It will become more permeable, and it will allow proteins to leak into the filtrate and finally to come out in the urine. This situation is known as the proteinuria, proteins in the urine. In minor damage, if only albumin, which is the smaller protein, it gets filtered into the filtrate and will appear in the urine. This type of proteinuria is known as the selective proteinuria. Only albumin is filtered. But if the damage becomes a little more, other proteins, for example globulins, they will also get filtered along with the albumin. And now this is not selective proteinuria, this is non-selective proteinuria, because other proteins are also filtered with the albumin. But if the amount of protein that is filtered into the urine or into the filtrate is less than 3.5 grams per day, this we call as the subnephrotic range proteinuria, and the patient is having proteinuria but no nephrotic syndrome. However, if the loss of proteins becomes equal to or more than 3.5 grams per day, we say this is the nephrotic range proteinuria, and this patient will develop nephrotic syndrome. Usually, the presence of proteins in the urine gives the urine as a frothy appearance. So, that what we discussed is that nephrotic syndrome is the result of glomerular injury to the filtration barrier, followed by increased permeability and leakage of proteins. So, if the injury is mild, there may be selective proteinuria and only albumin is filtered in the filtration barrier. And if the amount is less than 3.5 grams per day, we say this is the subnephrotic range proteinuria. But if the injury becomes a little more severe, other proteins like globulins may also be filtered along with the albumin. But still, the loss of albumin is less than 3.5 grams per day. And this is subnephrotic range proteinuria. But this proteinuria, as compared to this one, this is non-selective. Here only albumin is lost, and here along with albumin other proteins are also lost. Now, if the same injury, if we think, if it is more severe, which may be selective or non-selective proteinuria, but if the loss of albumin is equal to or more than 3.5 grams per day, this is nephrotic range proteinuria, and it will give rise to the development of the nephrotic syndrome. As a result of the loss of proteins, there will be hypoproteinemia and hypoalbuminemia, and decreased level of albumin in the blood will cause decreased plasma colloidal osmotic pressure or oncotic pressure, and the blood will be unable to pull back the fluid that is lost at the arteriolar end of the capillary by the hydrostatic pressure, and the fluid will stay there and it will lead to the edema. Initially in the periorbital region, and later on it will become systemic. And as we have discussed, that as a compensatory response plus loss of those proteins that inhibit lipoprotein synthesis, what will happen that along with the albumin and other proteins, the liver as a compensatory response will start the synthesis of lipoproteins, LDL, VLDL, IDL, and this will lead to the hyperlipidemia. Now, increased level of the lipids in the blood, ultimately in the face of a damaged filtration barrier in the glomerulus, it will lead to excretion of the lipids in the filtrate and urine, and this condition is known as the lipiduria. Most of the lipids filtered by the filtration barrier are reabsorbed by the epithelial cells of the proximal convoluted tubules, and they appear as oval bodies in these cells. Now, we know that the loss of albumin through the damaged filtration barrier of the glomerular basement membrane will cause loss of albumin. The plasma albumin will fall. There will be hypoalbuminemia, and as a result, the plasma colloidal osmotic pressure will be decreased, and there will be leakage of fluid into the extravascular tissue that will lead to edema. There are certain secondary mechanisms that, instead of relieving edema, will further aggravate the edema. An example is, for example, the loss of albumin in urine and filtrate, and decreased colloidal osmotic pressure and development of edema will result in the decrease in the extravascular fluid volume or total volume of the blood. And this will lead to ischemia in many organs, but particularly the decreased renal blood flow and renal ischemia. We know that it will activate the renin-angiotensin system, renin-angiotensin-aldosterone system in the juxtaglomeralular complex, which is situated between the afferent arteriole and distal convoluted tubules. And the result will be that the angiotensin 2, which is a vasoconstrictor, it will cause vasoconstriction, and the aldosterone will increase the absorption of sodium and water. Now, this compensatory response will increase the blood volume. But unfortunately, due to decreased plasma colloidal osmotic pressure, the blood is unable to hold the fluid within it, and as a result, further fluid will leak out of the blood capillaries into the extravascular tissue, and the edema will get further aggravated. Moreover, when the intravascular volume or blood volume is decreased, what happens that the blood becomes more concentrated, known as the hemoconcentration, and the hemoconcentration will increase the osmolality of the blood. And we know that increased osmolality in the blood stimulates antidiuretic hormone release from the posterior pituitary gland. And at the level of the distal convoluted tubules, this antidiuretic hormone or ADH will increase water reabsorption in an attempt to increase the intravascular fluid volume or blood. But again, due to decreased plasma colloidal osmotic pressure, fluid again will leak out into the extravascular tissue, and the blood is unable to hold the excess fluid. So this situation will further aggravate the edema, and as a result, there is a vicious cycle of edema formation. And these compensatory and secondary mechanisms further precipitate and aggravate the edema formation. Now, as I said, that nephrotic syndrome is not a diagnosis. It is a clinico-pathological presentation of an underlying glomerular membrane damage. So, when we come to the causes of the glomerular membrane damage, we see that the causes may be primary, when the problem lies within the glomerulus or kidney, or sometimes the systemic diseases may cause damage to the glomerular basement membrane. For example, in diabetic nephropathy and in conditions like amyloidosis and systemic lupus erythematosus, they will cause damage as a secondary and bystander damage to the glomerular basement membrane and filtration barrier. And this type of Nephrotic syndrome is commonly seen in adults. When we come to the children where nephrotic syndrome is more common, mostly it is caused by primary abnormality or pathology in the kidney and glomerular basement membrane. And for example, the diseases, glomerular diseases, for example, minimal change disease in which there is loss of negative charge, and focal segmental glomerulosclerosis. These are the common causes of nephrotic syndrome in children, and they are primary because the problem lies in the kidney and in the glomerulus. And this type of nephrotic syndrome is commonly seen in children. So, whatsoever, but the damage to the glomerular basement membrane and filtration barrier will lead to nephrotic syndrome with increased permeability for proteins, proteinuria, hypoproteinemia, hyperlipidemia, and lipiduria. Now, let us simply explain some of the many more complications of the nephrotic syndrome. As I said that in nephrotic syndrome, there is increased proteinuria, more than 3.5 grams per day. And along with these proteins, the transferrin, which is the iron carrying protein, it is also lost in the urine. And it will lead to ultimately into the hypochromic microcytic anemia known as the iron deficiency anemia. So the anemia seen initially in the nephrotic syndrome may be partially caused by the loss of the protein transferrin, which is the iron carrier protein. Moreover, patients of nephrotic syndromes, they are exposed to thrombogenesis. Thrombus are clot formation in the blood vessels. So we know that the hemo concentration or decreased fluid in the blood cause hemo concentration and stasis. And we have studied in hemodynamics that stasis predisposed to thrombosis and clot formation. Additionally, there are antithrombotic proteins which inhibit the formation of clots in the blood vessels, and particularly the antithrombin third. So along with other proteins, the loss of these anticoagulant proteins in the urine will also make the person vulnerable and more exposed to the formation of thrombi and clots. We know that immunoglobulins and complement proteins, proteins of the complement cascade, the very important 9 proteins, they have got very important role in our immune system to fight against infections and protecting the person from bacterial, viral, and other infections. So what happens in nephrotic syndrome? That these immunoglobulins or antibodies or immunoglobulins and complement proteins, they are also lost in the urine. And as a result, the persons become deficient in these immunoglobulin and complement proteins, and this deficiency make the person more susceptible to infections. As I said that the hypoproteinemia causing edema, and this hypoproteinemia cause a compensatory increase in the lipoprotein synthesis of the liver, and this will lead to hyperlipidemia, and if the lipids are excreted in urine and are filtered, this will lead to the lipiduria. So summarizing the possible complications of nephrotic syndrome, there is edema, which initially appears in the periorbital region and later on it becomes generalized and may lead to severe form of edema known as the anasarca. A patient of necrotic syndrome is said to be having in a hypercoagulable state because of the loss of anticoagulants proteins antithrombin third in the urine. Decreased fluid volume lead to hemoconcentration. The blood becomes more concentrated and more susceptible to stasis, which is a prothrombotic situation, and clot formation may occur. And moreover, the presence of excess lipids in the blood not only cause endothelial injury, but it also turns the blood into a procoagulant or prothrombotic state. The other complication of that occurs in nephrotic syndrome is the high blood cholesterol and elevated blood triglycerides. And hyperlipidemia and derangements of lipid metabolism can be the cause of many diseases like vascular diseases, myocardial infarction, cerebral strokes, and peripheral vascular diseases, atherosclerosis, and many other conditions. When a patient is using protein, when a patient is losing protein, he will suffer from malnutrition. And additionally, the loss of transferrin, which is the iron carrier protein in the urine, will lead to iron deficiency anemia. And the low level of vitamin D may cause hypocalcemia with its effects and consequences on the bones and other body tissues. Now, what happens that when the glomeruli become damaged, what happens that there is increased resistance to the blood flow, and this will lead to hypertension. Moreover, the presence of excess body fluid is itself is a cause of elevated blood pressure. Long-standing nephrotic syndrome will lead to chronic kidney diseases and the loss of immunoglobulins and low molecular weight complement proteins make the person more susceptible to infections. The investigations of a patient with nephrotic syndrome depends on the clinical presentation and sign symptoms of the patient, but commonly we make urine examination. We examine urine sediment for the presence of proteins, glucose, and other crystals, and we measure the protein in the urine to assess the loss of protein. By measuring the plasma or serum albumin level, we can also have an idea about the hypoproteinemia. And we also do some serological tests for the identification of infections and some immune abnormalities. Imaging of the kidneys like ultrasound and other imaging techniques are used to find out an abnormality, particularly structural abnormality in the kidneys. And finally, the renal biopsy is very important for to find out the underlying glomerular abnormality. Now, we will study nephrotic syndrome in a separate lecture, but here I want simply to say that in nephrotic syndrome there is proteinuria, and it is caused by the increased permeability of the filtration barrier. But sometimes there is very severe injury, and this injury is associated with inflammation and hypercellularity and cellular proliferations. Now, this will be a different situation in which with proteins there is loss of red blood cells and red blood cell casts. Now, this condition is the Nephritic syndrome, and this condition is associated with loss of dysmorphic red blood cells and red blood cell casts. There may be hypertension, and this severe condition may lead to, if the urine output is less than 400 milliliter per day, this will lead to oliguria, and as a result, the decreased or reduced GFR, there will be buildup of waste products like blood urea nitrogen and creatinine, and a situation of azotemia will develop. However, if the azotemia becomes symptomatic, then we call this situation as the uremia. And usually in nephrotic syndrome, the loss of protein is less than as seen in nephrotic syndrome, and the edema is less marked as compared to that seen in the nephrotic syndrome. And we will study the nephrotic syndrome in a separate lecture. Thank you very much.